In this unit, we're going to be talking about spinal cord injury. Spinal cord injury rehabilitation really does stand alone a little bit as a specialty area. You could see somebody acutely or in neurological rehabilitation settings, but I think it's important, especially because as orthopedic practitioners, you may see people that have had spinal cord injuries that come in for care post-injury, as well as you might be discovering a spinal cord injury during an examination. And so we'll look at this because we often think about spinal cord injury primarily from a traumatic event, which we see here that car accidents make up a good percentage of individuals that sustain a spinal cord injury, as well as falls, especially in the elderly population, and of course, less or so from violence or sports. But there's also a good number of conditions on the right-hand side of the screen that will not happen traumatically and that an individual may actually seek help from a physical therapist. So we think of these as things that we really have to watch out for as red flag conditions. The individual might have a spinal abscess, which is an infection, a spinal tumor. They might have vascular conditions such as either an infarct or arteriovenous malformation. Other neurological problems such as multiple sclerosis or orthopedic conditions such as spinal stenosis are also common and can cause a spinal cord injury, as well as transverse myelitis, which is actually an inflammation of the spinal cord itself. So we're going to take a quick look at what those will look like. And so if you think about transverse myelitis with that infection actually within the spinal cord, you can see that that would be an area of damage, as well as stenosis over here on the right side of your screen, where the bony encroachment will put pressure on the spinal cord. And then even though we haven't really covered multiple sclerosis, I think this visual kind of gives you the idea that with multiple sclerosis, you can have damage in various parts of the spinal cord. And we'll talk a little bit later about how those presentations will be different based on where the lesions are. When we're thinking about demographics, 80% of patients with spinal cord injuries are male and 20% female. That's a very big difference. It has to do with maybe risk-taking activities in this 15 to 29-year-old age range. We see a very distinct pattern where individuals are at risk for spinal cord injury in that age range, and then later after 65 years of age when they're at a greater risk of falls. And then we're going to talk a little bit about the demographics based on the extent and the location of the injury. So we think of those with quadriplegia or tetraplegia is the newer terminology, as having all four limbs affected, as you see in this person. So I think you're fairly familiar with quadriplegia, tetraplegia versus paraplegia, where the individual is more affected in the trunk and lower extremities, but you're probably not yet used to thinking about a complete versus an incomplete lesion. In a complete lesion, the individual has total transection of the spinal cord, and they've lost all motor and sensory function below that lesion. In an incomplete lesion that we see in this image, as well as this fourth image here, there are areas of function where the spinal cord is still functioning and messages can get all the way down to different parts of the musculature and possibly different areas of sensation. So we'll learn a little bit more about that as we learn how to classify injuries, but for now, just be aware that you can have complete or incomplete lesions, as well as we're thinking about individuals from a tetraplegic versus a paraplegic level. And you can see here that the highest percentage is the incomplete quadriplegia, followed by the incomplete paraplegia, and then complete paraplegia, and finally by complete tetraplegia, which is fortunate because that is by far the most severe category. And I think if we all consider a spinal cord injury, we understand the nature of how disrupting that kind of a diagnosis would be. So when we think about that, we can think about it through several different ways. And one of the biggest impacts initially is from a very lengthy hospitalization. By our standards, even this is a little bit longer than we're typically used to seeing, 11 days in an acute care hospital, and then followed by longer than a month in an inpatient rehab. But a long time ago, that was even more lengthy. So individuals would stay at acute care for nearly a month, and then followed by a 3-month or so inpatient rehab stay. And what I learned, I worked at Woodrow Wilson Rehab Center, which saw a good number. They were really the state's regional center for spinal cord injury rehabilitation. Is that individuals were having a hard time processing the spinal cord injury just in and of itself. And so many times the focus was to get them home and to get them safe, and then they could come back for a more intensive rehabilitation period when they had specific functional goals that they wanted to meet. I don't know if you can see the name of this table, but here we're really looking at financial impacts of the injuries. And both the financial impacts and the life expectancy is very much driven by the location and the extent of the lesion. You can see up here both the first year and the average lifetime of an individual that sustains a tetraplegic injury, especially up in the higher cervical area, would incur a great deal of expenses and is still significant even at a lower tetraplegic level. And though the costs are still significant at paraplegic level, you can see that it's vastly different from a tetraplegic level. And looking at the life expectancy, this is the life expectancy for an individual, a 20-year-old, who has not sustained a spinal cord injury, is close to 80 years of age. And then you can see as we go down the table, just with an incomplete injury, the individual has lost about 6 to 7 years of life expectancy. And that goes all the way down to the high-level tetraplegic patient who really is only close to about a 57-year-old life expectancy. And that's quite decreased from somebody that does not sustain a spinal cord injury. And we think about that because they're going to sustain a lot of medical complications along the way, as well as extensive follow-up medical care and recurrent complications based on that level of injury. All right, so we're going to move into some spinal anatomy review, which will help you to understand some of the classifications and some of the specialized syndromes that we might see. So we're going to look first at the vertebral segments, and I know you guys are rock stars and you remember all of your anatomy: 7 cervical vertebrae, 12 thoracic, 5 lumbar, the sacrum, and the coccyx. And we know that each of those areas, they carry a very unique shape and morphology of those vertebral segments. And that's really going to drive some of the presentations that we see from injuries in each of those areas. So if we look at the spinal cord, we're reminded that the spinal cord section itself with the paired nerve roots, dorsal and ventral, is different than the corresponding vertebral level. This is going to be very important as we move forward, so we're going to pay special attention to that. In addition, don't forget we have 7 cervical vertebrae, but 8 cervical nerve roots. Okay, so in the beginning, the nerve roots exit ahead of the vertebral segment, but as you get down to C7, that's when C8 exits below the vertebral segment, and then so on and so forth. And as we move through, we remember that the spinal cord itself only goes to about L1, L2, depending on the individual. And so these nerve roots are not always exiting exactly with their vertebral level. So a lot of times you're going to get medical records that will tell you the level of the fracture. You have to keep in mind that that level of the fracture will not necessarily correlate with the spinal cord segment that's injured. And we're going to talk about that a lot more as we move forward so that you can, as we learn how to classify injuries. So when we're thinking about our cervical spinal cord segments, those are going to correlate with the vertebra C1 through C7. The thoracic spinal cord segments are mostly going to be found correlating with vertebra C7 through T11, and the lumbar from T11 to L1, and then our sacral segments will be correlating with L1 and L2. So again, just a reminder here that the vertebral level is not going to line up with the spinal cord segment. Okay? And when we start to look at it here, we can get an even better appreciation for that because we can see that up near the top, they're exiting very close to the vertebral level will match up with the vertebral segment. But as we move down, you see a longer delay from where it exits the spinal cord and where it comes out between the vertebral segments. So as we go down, it's longer and longer yet. Another gentle reminder here that the conus medullaris is the end of the spinal cord here. And so the important thing to remember here is that a spinal cord injury is an upper motor neuron lesion. Whenever we damage the spinal cord itself, it's still part of the central nervous system. But the conus medullaris here is going to present both with upper motor neuron and lower motor neuron signs. And you can see that those nerve roots and the conus medullaris are traveling really close together. And that is why you'll see a presentation of both upper motor neuron and lower motor neuron. And then a cauda equina, where the cauda equina is just made up of the nerve roots, right? And so if you think about that, then the cauda equina will be different and it will only be a lower motor neuron injury. Okay? So nerve root injuries are lower motor neuron because the root has already exited the spinal cord. And we're going to think about that as a peripheral nerve injury. And their peripheral nerve injuries, again, are lower motor neuron injuries. Here's another, a better picture perhaps of that, where you can see the number of nerve roots that might be injured when the conus medullaris is injured, as well as you can see here that the cauda equina would only be injury of the nerve roots. So when we think about classifying a spinal cord injury, the level of the spinal cord injury, the way that we name it, is the lowest level where both the sensory and the motor function are intact. So the neurologic level of injury is the lowest level where both sensory and motor function are intact. So if somebody is a C7, that means that the C7 nerve root is intact and they have both sensory and motor function there. And again, the spinal cord segments are not the same as the vertebral body segments. That's going to be an important part, and we're going to pay close attention when we get to the conus medullaris and cauda equina and what that presentation is going to look like. Spinal cord injury is an upper motor neuron injury, and so you're going to see spasticity, clonus, upgoing Babinski, and positive Hoffman's depending on that level of the lesion. And so that's where you're going to rely on some of those examination techniques to help differentiate that, especially in some of those presentations that weren't caused by a traumatic lesion. Okay? Gentle reminder then that the conus medullaris is a mixed upper motor neuron and lower motor neuron injury, and the cauda equina is a lower motor neuron injury. When we look at the diagnosis of the spinal cord injury, again, that's where some of those signs are going to help us, especially in the non-traumatic. So you are going to remember very carefully your upper motor neuron signs, and you're going to be able to recognize those, thinking about lower motor neuron signs as well. So when we think about primary injury, we think there might be a vertebral fracture, subluxation, or a dislocation as a result of that trauma that puts pressure on the spinal cord. Okay, it begins in the gray matter, and there's going to be a lot of vasculature around that will shear and rupture. And those white matter axons will be directly lesions. So you're going to think about all the hemorrhage and the tissue laceration and the edema that's going to happen as a result of the primary injury and necrosis of that tissue. Following that primary injury, like some of the other mechanisms that we've learned about earlier, there's going to be a secondary injury as a result. You're going to see ischemia, inflammation, and other programmed cell death as a response to some of that toxic environment that's been created from that initial injury. So you're going to see the area of damage from the secondary injury is much greater. And here's a nice reminder of the blood supply in the spinal cord, because we need that blood supply to get in there. We have a lot of blood coming to the area, and thinking about the anterior spinal artery and the posterior spinal arteries and the area that they serve. So you can see we've got quite a bit of blood flow getting to that important tissue. And when we have that secondary injury, you can see the ischemia from some of the rupture or the compression of some of those blood vessels. You're going to also possibly see vasospasm or blood clots, edema, and areas of vasoconstriction trying to sort of shut off and wall off that area, with expanding inflammation and necrosis, and problems from that ion derangement due to the injury, right? Sodium and potassium balance gets disrupted, and you're going to have more cell death. Can happen both in the myelin as well as the axon surrounding the tissue. So we term this spinal shock, and you're going to see a depression, initially a depression of neural activity in the spinal cord. And we've talked already before how in the initial stages of neurologic damage, you can actually see hyporeflexia. Okay, that damage there is referred to as diaschisis, and you're going to see the reflexes below the level of injury being absent or very weak. Over the next few days to months, you're going to see some of that calm down, and you can have some return of function from areas that were uninjured initially. And as that happens, you as the clinician may be looking out for signs to see when the hyporeflexia is moving to hyperreflexia. So you're going to be keeping an eye out for a return of a Babinski or a deep tendon reflex, for example.